Thank you, Linda. Good morning, everybody. My talk will focus on mid-urethral sling for stress urinary incontinence and mainly on the French perspective because there is no recent data about all Europe apart of the UK. This is my disclosure. We still use a lots of tapes, at least in our practice in France, and is still the first line of treatment of surgical treatment of stress urinary incontinence. As you know, there is lots of data about tapes, and there is also long-term follow-up data. Even if this study by Nielsen is a small sample size, it has been followed for 17 years with excellent results at long term with this cohort, with 90% of the women objectively continence at long term, and with 87% of women with subjectively cured or significantly improved. There is a high satisfaction rate of retropubic tapes and a low morbidity in that short cohort, with a 1.2% of tape extrusion and no other tape complication that occurred at long term, with no serious adverse event that have not been judged at the beginning. In most of European guidelines, and including French, but not only, the mid-urethral sling has to be the first line of treatment that could be offered to patients, and this is the last year European urology guidelines. We said that offer a mid-urethral sling to women for uncomplicated stress urinary incontinence as the preferred surgical intervention whenever available. There is also some pathway that have been published in Europe. This is an Italian study about the management of stress urinary incontinence that shows that in uncomplicated stress urinary incontinence, the surgical therapy with mid-urethral sling has to be proposed at first line. We could use a bulking agent in some patients with comorbidities as an alternative to mid-urethral sling, and for moderate stress urinary incontinence, we could offer some other option like the laser treatment. In the French guidelines that have been published in 2015, but it's still followed by our colleagues, the retropubic mid-urethral sling can be performed as a first-line surgery, even if there is an intrasex factor deficiency, and in case of a lack of urethral mobility associated with an ISD, the artificial urinary sphincter remains the gold standard in France, which is also a particularity, and we can have some alternative of the artificial sphincter, which could be injectable bulking agents in elderly patients or adjustable continent therapy, but as an alternative option. The retropubic mid-urethral sling is still the first option if there is a urethral mobility, even in case of ISD. In case of recurrences or complicated stress urinary incontinence in women, once again, the European urology consider that a secondary sling could be an option. Even in this particular case, it could be also discussed to use a colpo suspension or an autologous sling in case of recurrences. Why don't we use the Birch colpo suspension again? At least in our practice in France, but at least I think it's quite the same in several European countries. There is different reason for that. The first reason is that evidence that have been published 2 years ago in the European urology show that there is a subjective and objective success rate which is better with mid-urethral sling in comparison to the Birch colpo suspension. The second reason is about complication, because even if tapes for synthetic tapes for stress urinary incontinence surgery have been banned from several countries, almost in the UK, there is some complication that could occur with the Birch colpo suspension, including long-term complication, and it's not rare to find some suture inside the bladder on patients with overactive bladder or recurrent urinary tract infection. There is also some bad cervico-urethral obstruction with the Birch colpo suspension, and there is some quite recent paper in the literature showing that when you have an obstructive micturition after birch colposus suspension is even harder to deal with the patient because you have to do an uretrolysis, which is not the case with tape surgery, or it's possible to just revise the tape by a transection of the tape. There is also some doubt about a long-term prolapse of the posterior compartment using the birch colposus suspension. Even in that field, there is only 2 studies. One study is 2 small studies. The first one is a French one, showing that you could have up to 12% of posterior vaginal wall prolapse after a birch colposus suspension at long term. And one study by Kaven-Bessler in Germany. It's a small study as well. It was not significant, but you see that you can have up to 36% of posterior vaginal wall prolapse at long term after a birch colposus suspension. The other argument against the birch is also the problem of ISD, because, and it has been shown in this in that meta-analysis of the FIGO, in patients with ISD, the birch is has a lower efficacy in comparison to the retropubic midurethral sling. So in conclusion, in most European countries and mostly in France, obviously except in the UK, the retropubic sling is still the gold standard for stress urinary incontinence, either for the first line surgical treatment with or without ISD, and which is a very good things in comparison to the birch colposus suspension, and even if in case of recurrences. The birch colposus suspension is still efficient in stress urinary incontinence, but without ISD, but has also specific complication. And if we start again to use colposus suspension in our practice, most of young surgeons will have again to start an on learning curve, which could induce also some specific complication. Thank you very much.